afternoon, everyone. Thank you very much for inviting me to do this talk today. I'm Vicky Milner. I'm a final year trainee clinical psychologist at the University of Oxford. I'm currently on placement, my final placement, in a homelessness charity in Oxford. Prior to starting the Doctorate in Clinical Psychology, I completed a PhD that was looking at barriers to diagnosis for autistic women and girls. And I've continued my interest working with autistic people and conducting autism research throughout my doctoral training as well. So today what I'm presenting is one of my projects from my thesis, and it's titled Recognition of Autism in Homelessness Services and Related Adaptations to Support. So I think, given the title of the group that's coming today, I probably don't need to describe what autism is to you, but just so that we're all on the same page, autism is a neurodevelopmental condition. It is characterized by differences in social interaction and communication styles. So that encapsulates a range of different presentations, such as differences in verbal and non-verbal interaction. That could be to do with gestures or eye contact. It might be the way that, that someone uses their words. Some people might have idiosyncratic phrases that they like to use, or talk in a very literal manner. And there might be also differences in understanding relationships and preferences for how they make and maintain relationships as well. The second criteria that someone needs to meet to get a diagnosis of autism is the restrictive and repetitive behaviours and interests. And in the most recent edition, they also added sensory differences into the diagnostic criteria as well. So these criteria are more around the sort of preference for sameness, preference for routine, and those more passions and long-lasting and intense interests as well. And sensory differences can include both hyper and hyposensory differences, and also sort of sensory seeking as well as sensory aversion. And that can be a range of different senses. So the most common ones are sight, scent, touch, smell and taste, and sound. And but it also includes things like temperature, proprioception, movement, interoception, which is understanding internal cues. And these differences are really common for autistic people as well. So in terms of the prevalence of autism, in the general population, our current estimates are around 1% of the general population, although we could do a whole other talk about whether or not this is an accurate representation. There's a general, I guess, debate or discussion at the moment around whether this is an underestimate of the population. But the main reason I'm bringing this today is actually that research looking at the population of people experiencing homelessness has recognised that there's a significant overrepresentation of autistic people experiencing homelessness. So one piece of research by Alistair Churchard in 2019, they spoke to, I think it was around 100 key workers working with people experiencing homelessness. And through those discussions with a key worker, they looked at the criteria for diagnostic criteria for autism, and they found about 12.3% of the sample would likely meet a diagnosis of autism. Now, it's important to say that we're not saying that 12% of those sample had a formal diagnosis, but based on the informant feedback, which is also part of the diagnostic process, about 12.3% would likely meet criteria. This also represents barriers to diagnosis as well. So within this sort of project, we were considering people who have high autistic traits and would likely meet a diagnosis, not just those with a formal diagnosis as well. So let's think a bit about what might contribute to increased vulnerability or elevated risk of homelessness for autistic people. And I've separated these out into sort of autistic traits, things to do with sort of more of the individual, and also more systemic factors, so the wider system around them, more societal factors and the relational factors with other people. And although I've separated them like this, I think actually it's important to note that there's a massive overlap and interaction between these various factors. But if we think about autistic traits, also keeping in mind that there's a massive variation in autistic presentations. There's a saying that many of you have probably heard, it's quite I guess overusing cliched now, that once you've met one autistic person, you've met one autistic person. So it's important to keep that in mind as well as I'm explaining this in a more of a generalized way. But many autistic people have less flexible thinking styles. They might have difficulties or differences in their executive functioning. So by that, it means a range of different abilities in terms of problem solving, decision making, working memory, making predictions for the future or reflecting in the past, organisation. Those are all encapsulated within executive functioning. And for a lot of autistic people, there might be difficulties within executive functioning skills. Many autistic people have a preference for sameness. So if we think about, I've just realised I've not related this to increased elevated risk of homelessness, but if we take those top two, so that executive functioning and thinking styles, if we think about all of the tasks that are involved in finding and sustaining housing, think of all of the documents you might have to sign, or the things you might have to negotiate, how you even navigate getting to an estate agent's, for example. How do you know what area you want to live in? All of the decisions you have to make around finding a house, and then all of the decisions you have to make while sustaining housing as well. Then in terms of preference for sameness, if you are not living independently, or even if you are living independently, there can be so many different variables that happen. So there might be, for example, a landlord that spontaneously changes something that can be really distressing for an autistic person, and that then might lead down to break down that relationship, which then might lead to increased risk of homelessness. Sensory differences is a really big factor that can contribute to homelessness for autistic people. If we think about the suitability of housing, if you have a sensory difference, if you, for example, are very hypersensitive to sound and you have quite noisy neighbours, it can be really distressing and intolerable to live in that environment, and therefore that can then lead you to want to leave, and it might be preferable to be street homeless compared to being in that unsuitable, intolerable environment. Social differences, so we've talked a little bit about that, navigating the system, so estate agents, landlords, or mortgage advisors, whoever it might be within that system, or the council, whoever. There's also, if we think about living with a family or a partner or flatmates or housemates, there are so many dynamics and relational things to consider within that that can be vital for maintaining housing, which can be quite different or difficult if your communication style doesn't match the person that you're communicating with. And that then also ties into the maintaining relationships. So breakdown of relationships could be more common for autistic people, and therefore that then might lead to lack of housing if a relationship breaks down. Then if we think about systemic factors, so wider system factors, one of the most important things, I guess, is around lack of understanding. So if you are working, even if before you become homeless, you're working with all of these people within your system to access independent housing or sustainable housing or suitable housing or even supported housing, and that person isn't understanding you or recognizing that you have a preference for how you communicate or how you behave in a situation or how you can tolerate a situation. If that lack of understanding is there, then it's likely to lead to a misinterpretation of things you might be saying or your needs, and it might be even more difficult for your needs to get met because that other person has not understood you or recognized your needs. Stigma and discrimination is often reported by autistic people that can lead to a breakdown in housing, and then also difficulties accessing housing services or homelessness services as well. We've talked a bit about unsuitable housing, but not only sensory differences, that can also can include things like, I did some research previously that spoke to lots of different autistic people about their experience of moving home, and a few people shared with me their experiences of living in very different settings, but having things like rat infestations or damp, broken windows, broken appliances, and finding it really difficult to navigate how or even be heard from other people about those issues and get those issues dealt with. And that also ties into those two above, that stigma, that discrimination, the lack of understanding as well. I guess almost most relevant to this project, if there's no recognition and no understanding of autism or autism related needs, then there's unlikely to be put in place reasonable adjustments. And that can be all throughout the process of finding somewhere to live, sustaining somewhere to live, and accessing housing services if you do become homeless. Underemployment is a massive issue within autism populations. So this is evidence in lots of the literature. But if you're finding it difficult to get a job, then you're not likely to have an income, therefore you're not likely to be able to sustain housing. And then finally, barriers to healthcare. There's a vast amount of literature that talks about autistic people having barriers to accessing healthcare for those different reasons. But if you have co-occurring mental health or physical health condition, that again can lead to difficulties sustaining housing and difficulties accessing services to prevent homelessness, or if you do become homeless, to access support. So why think about working with staff or asking staff about whether or not they can recognise autism within homelessness services? So if an autistic person becomes homeless, I guess accessing services is a whole thing to even get through the door. But once someone is through the door, one of the most important things is a person recognising their needs. And that goes for everybody, regardless of whether they're autistic or not. But in particular, thinking about if a staff member is able to recognise autism, that can then lead to appropriate support, which we know predicts positive outcomes as well. A staff's ability to recognise autism can reduce bias and misinterpretations of behaviour. So, for example, if somebody has different facial expressions or different eye contact, one person might interpret that as someone not engaging or being rude or not listening or not wanting support, whereas actually if the staff member is able to recognise that this could be an autistic trait, this could be explained by that person being autistic, then it can reduce that bias, reduce misinterpretations, reduce blame and stigma. Another important thing is reducing overshadowing of other diagnoses. So we know that within homelessness populations, there's a big prevalence of mental health conditions. So particularly things such as anxiety and depression, but also personality disorders and psychosis are prevalent in homelessness populations more so than in the general population. And sometimes traits of autistic traits can be misinterpreted or overshadowed by these other diagnoses. Now, that's not to say that an autistic person can't also have a co-occurring diagnosis of personality disorder or psychosis or mental health condition, but what we hope would happen would be that someone able to recognise autistic needs compared to those mental health needs and understand that person at all levels as well. It's also important for staff, if they're able to recognise autism in a service user, they might be more equipped and confident and empowered to advocate for that person's needs and understand what that person's needs might be. It might also open up conversations with that individual about how they like to be supported, and it could be the first time that they've ever been asked those questions. But the recognition is that initial stage, that initial first step to be able to do that. And then finally, it's important because in recent years, there's been a massive push from government to improve access to care, both healthcare and social care for autistic people. So this project was driven by that as well. So this particular study then, we aimed to explore the extent to which staff working in homelessness services identify autism in service users and whether staff consider making adaptations to service users' support. We had 3 different hypotheses for this research project. So the first one was that staff working in homelessness services will identify autism in service user vignettes less accurately than other diagnoses. And that hypothesis was driven by the idea that there is a high prevalence of other mental health or co-occurring conditions within homelessness populations, and that staff might be more familiar with those presentations than they would be with autism. We also predicted the second hypothesis that the accurate identification of autism would be predicted by prior experience. By prior experience, we meant both personal and professional experience. So by personal experience, we meant, are they autistic themselves, or do they have any other neurodivergent condition? Do they have an autistic person in their life? And that could include a family member, a friend, a romantic partner, a colleague. And then professional experience, we meant, have they worked with an autistic person before? Have they had training specific to autism before? How many autistic people had they worked with in the past? And then our final hypothesis was also thinking about that personal and professional experience. Does that predict whether or not staff would say, yes, I'd make adaptations to the support that I offer for service users, an autistic service user? So then going on to our methods and what we actually did. So we had an online survey. Some of you in the audience might have taken part, so thank you very much if you did take part in our survey. And within that survey, we created vignettes. So vignettes are descriptions of hypothetical service users. And I'll tell you a bit more in detail about those vignettes in just a moment. We collected data between January and October last year, so 2024. And because all of our participants were paid for taking part in the study, we had an extra step. So we asked people to express an interest in taking part before they were sent the survey link to avoid, there's quite a problem with like bot data and things like that. So we wanted to try and avoid any artificial data. And also that meant we could confirm that the person was signing up to the study with an email address linked to a homelessness service. So we had an extra step. They were then sent a link and they took part in the survey. After the survey ended, they were sent a voucher. And then importantly, none of the participants were told at the start of the study that the specific focus was about autism. We framed it as staff recognition of service user needs. So it's very broad, thinking about any needs that any service user might have. And then once all of the data was collected in October 2024, we sent a debrief email to our participants that explained we were particularly looking at our hypotheses were around autism as well. I feel like I've forgotten to mention something on this bit, but hopefully it'll come back to me, and if not, it might come up in questions. So then thinking about the vignettes that we developed. So all of our vignettes were co-developed with experts by experience. So these were individuals who had experienced homelessness and had a diagnosis or self-identified as either autistic, had a diagnosis of psychosis, or a diagnosis of emotionally unstable personality disorder. And so we chose these 5 vignettes. We had traditional autism, and by that, we really struggled to think about how to name traditional and nuanced autism. But by traditional autism, we meant the more sort of stereotyped traditional view of what an autistic person might present like. And then it might be easier to explain that in context to what we meant by nuanced autism. So nuanced autism, we related to what in a lot of the research studies is referred to the female phenotype of autism. And this has emerged, or has been more understood, at least in terms of academically, over the last sort of 10 years. And it's more predominant in females, but anyone of any gender might present in a more nuanced way. And the idea is that someone with a nuanced presentation of autism or a more internalized presentation of autism would have more subtle traits that might be interpreted differently. But once you speak to that individual and hear their experiences, it meets the diagnostic criteria of autism. These people might be more likely to mask or camouflage and use strategies to fit in more so than someone with a traditional autism presentation. And I'm not saying that's a conscious choice. Often it's almost been socialized and it can be an unconscious choice as a protective factor to fit in socially, but underneath it can be really a challenge to mask and really exhausting to mask. I just realized I'm going off on a bit of a tangent there because that's what my PhD thesis is about, but I'm going to swiftly come back to this project. So we had the traditional autism vignette and we had the nuanced autism vignette. We then chose psychosis and emotionally unstable personality disorder due to the, as I've mentioned previously, the high prevalence in homelessness populations. And then we had a control vignette as well. And what we meant by this was it's a person experiencing homelessness, but within the vignette, we didn't detail or allude to any co-occurring mental health condition. The way we developed the vignettes, so the first step was to come up with a framework. We wanted all of the vignettes to capture the similar information, even though it was going to be written in a slightly different way. So all of the vignettes started with the same sentence. It gave context to the reader about why that person had come to you. And I'll show you an example in just a moment. All of the vignettes as well were given gender neutral names. We used they pronouns throughout the vignette, so we didn't specify any gender. And we also tried to choose names from various cultures. They weren't all sort of English or British names that we chose as well. Then each of the vignettes followed this framework. So the first sentence was, what were the problems with the temporary accommodation? Why has this person come to your homelessness service? The second was, what was the key event leading to their first experience of homelessness, or so the reason why they've become homeless? The third sentence then talked about the first contact with the homelessness services from the perspective of the service user. And this will all make sense in just a minute when I show the example. The fourth sentence then talked about the first contact with the homelessness service from the perspective of your colleague, so the reader's colleague. And then the last sentence, the perspective of the contact from the reader's perspective. So let me tell you what I mean by that. So I've tried to color code this, but now seeing that on this color slide, I realize it's actually not that clear. But the first bit in bold, the black bit, is the sentence that all of the vignettes had. So I'm just going to read this out. So you're working with Rayanne, who is in their 30s and currently experiencing homelessness. You've received a referral from a local authority as their temporary accommodation arrangement has broken down and they're at risk of rough sleeping. So the next sentence is thinking about what was the problem with the temporary accommodation. So Rayanne does not want to live in a group environment and is looking for a self-contained accommodation. Then this sentence is thinking about what was the key event leading to homelessness. So Rayanne became unemployed after making multiple complaints about co-workers not meeting Rayanne's expectations about reasonable behaviours, e.g. excessive noise, being late, not following workplace rules. This resulted in Rayanne not being able to afford their rent and subsequent eviction. So then the next sentence is about Rayanne's experience first accessing your service. So at their first appointment with the homelessness service, Rayanne stated a preference to have appointments at the same time and place each week. Then this sentence is about your colleague's perspective. So your colleague commented that they noticed Rayanne rarely made eye contact and appeared anxious. Rayanne repeatedly shared their experience in rented accommodation. And then the final sentence is your perspective or the reader's perspective. So you've noticed that Rayanne is more animated when discussing their favourite sports team, but otherwise seems quite reserved and difficult to engage. So that's the example of what we coined the traditional autism vignette that was co-developed with two autistic people who'd experienced homelessness. So we then, we developed these vignettes with experts by experience, and we then wanted to make sure that they were capturing the diagnostic label that we thought they were capturing. So we had a validation phase where we sent all of the vignettes in an online survey to clinical psychologists and trainee clinical psychologists, and we asked them to read each of the vignettes and then answer the question. So please state the diagnosis, if any, you think the service user may have. Please only enter one diagnostic label. If you think that, if you do not know or are not sure, please state not sure. And if you think the service user has no psychological diagnoses, then please put no. So we had 56 psychologists take part in the validation phase, and we were checking this regularly to see what the agreement rate was between the raters. And after 16 participants, we recognised that the EUPD vignette, so the emotionally unstable personality disorder vignette, had a really low agreement. And there is a bit of a discussion within the literature about EUPD. We don't have time to think about that right now and sort of how it's conceptualised as a label. But we wanted to go back and edit that. So we did tweak that vignette with two further experts, one expert by experience, one expert by profession, and tweaked it. And then overall, all of the agreements were above 65% once we put it to the main study. So in the main study then, so we validated the vignettes. I got in contact with loads of different homelessness services across the UK, and we invited people to take part in that online survey. They sent me an expression of interest, and then they got sent this personal link to take part. They initially got shown each vignette in a random order. And after each vignette, they were asked that same question as in the validation study. So in an open text box, just to add a label about what, if any, diagnostic labels they think this person might have. Then after they'd answered in the open text box, they were shown a scale with 0 being the least likely and 100 being the most likely. And they were asked, how likely is it that this service user would meet the following criteria for the following diagnoses? And we included more than just what we'd depicted in the vignettes to give some red herrings, I suppose, so to give some distractions so that people didn't immediately determine what we might be looking for within the vignettes. So that's we had autism, depression, generalized anxiety disorder, personality disorder, psychosis, and substance use as the options that people could rate how likely they think it is that that person would meet criteria. We also then asked people what would you make adaptations to the support that you provide to the service user related to their diagnosis or potential diagnosis? And they could put yes, no, or unsure. If a person put yes or unsure, we ask them to then detail what would you do? What would the adaptations be? As touched on briefly earlier, we also, so once they'd done the vignette questions, we then asked people demographic questions, so gender, age, ethnicity, job title, what the services that they work in, and what UK count, that says country. Oh no, we did ask country actually, and county, which county they worked in. And in terms of experience, we asked about professional experience and personal experience, which I touched on briefly earlier. So what did we find? How am I doing for time? Okay. So we had 203 participants take part in the end, which was amazing. Again, thank you if anyone in the audience did take part. Participants were aged between 20 and 69, with the average age of 41.5. The majority of our participants were female, which is really quite common for online surveys. But we did have about a third of, well, 29% of people were male, and then a few individuals were either non-binary or preferred not to say. The majority of our participants were white British, and the majority of people were living in England. So we then also asked about personal experience. So the majority of our participants were not autistic themselves, although 4% self-identified as autistic, 2% had a formal diagnosis of autism, so that's about 4 of our participants. 1% was missing, and then 4% preferred not to say. We also asked about other neurodivergent conditions, and the majority didn't have any other neurodivergent conditions, but we had 13% with a formal neurodivergent condition and 13% with self-diagnosis, and 3% preferred not to say. And then interestingly, the sort of bottom middle one, I'm not sure if you can see my cursor moving around, but the bottom pie chart, we asked people who, if anyone, in their life they know who's autistic. And surprisingly, there was the vast majority of people knew an autistic person in their life. So there was only 20.2% of people who didn't know an autistic person. And the people who, so also I should say, sorry, these numbers don't add up to 100% in this pie chart, which I recognise is difficult for a pie chart. I was going to put it in a table, thought that looked boring, but people could add more than one person. So for example, they might have known a close family member and an extended family member. So this is the sort of percentage of the total sample that indicated that they knew they had a close family member or extended family member. So the majority, well, not the majority, sorry, 40% of people had a friend who was autistic, 35% had a close family member, 18.2% had an extended family member, 23% had a colleague who was autistic, and 9.4% had a romantic partner who was autistic as well. So in terms of professional experience then, the average years of experience was about 7 years. And we asked people how many autistic people had they worked with across their career. So that wasn't just in their current role, this was across all of their career. And the average was 29 autistic service users as an estimate, but the range was massive. So some people had worked with no autistic people, and some had worked with over, 1,000 autistic people. There was also the majority of participants worked in third sector or charitable organisations. And 25% worked in government or local authority. We had a few NHS workers and some people working in housing associations. The majority of people, so 86%, had worked with at least one autistic person. And interestingly, about 50% had received autism-specific training. So let's go back to the hypotheses. So our first hypothesis was that staff working in homelessness services will identify autism in the vignettes less accurately than the other diagnosis. And again, that was driven by this sort of under-diagnosis within general population and also within homelessness populations, and also the high prevalence of psychosis and personality disorder in homelessness populations. So the way we calculated this is we worked out an accuracy score for each of the vignettes. So we did this by taking that scale that we asked people to rank, how likely do you think this person is to meet this diagnostic criteria? And we took the participant score away from 100. So for example, for the autism vignettes, we would say the correct answer is 100 because we designed and developed those vignettes to depict and describe an autistic person. If the participant then had said, I think 80% likely, their accuracy score would be 20. So it took me a while to get my head around how that, but the lower the score, the more accurate the person is. So what did we find? We found, against our hypothesis, or in the other direction, participants were actually significantly more accurate at identifying traditional autism compared to all of the other vignettes. And I'll show you just the next slide is a diagram to describe that. Participants were significantly less accurate at describing the nuanced autism compared to the traditional autism presentation. And interestingly, the EUPD, so emotionally unstable personality disorder, was the least accurately identified vignette. So I've tried to describe in this diagram. The green lines are the significant difference, and traditional autism had a mean accuracy of 25.5, and that was significantly more accurate than the nuanced autism, the EUPD, and the psychosis vignettes. The nuanced autism had a mean accuracy of 34.9, and that was significantly more accurate than the EUPD only. The same pattern with psychosis, more accurate psychosis compared to EUPD, and EUPD was least accurately identified compared to all of the other vignettes. So that went against our hypothesis. And then I thought it'd be interesting, rather than just looking at the accuracy scores, what were the labels that people used to describe each of the autism vignettes? So these are all of the labels that people put in that open text box. So what label would you use to describe, if any, this service user? And interestingly, 79% of people did put autism. And I've just put autism here, but that included all different labels under the autism umbrella. So some people used, for example, ASD or Asperger's or autism spectrum condition, but I summarized them all within this label. So 79%, the majority, labeled this participant as autistic. Interestingly, the second most common was anxiety. And then the third was not sure. But yeah, like I said, the mean accuracy for this vignette was 25 to about, people were 75% sure that this vignette would be, would meet diagnostic criteria for autism. Then I thought it'd be interesting to have a think about what were the differences in the labels given for the nuanced autism presentation. So for the nuanced autism presentation, the majority, so 62%, used a label under the umbrella of autism. But interestingly, about 14% of people, nearly 15% of people, were not sure about what label they would give this person. And the third most likely answer was personality disorder. And that's really interesting because in the literature, if we think about nuanced autism being around the female autism phenotype, a lot of autistic women had previously been diagnosed with a personality disorder, particularly EUPD, before getting that autism diagnosis. And there's a big conversation around that misdiagnosis of autism as a personality disorder. So I thought that was quite interesting, that the third most common label, although it was only about 8% of people, it's quite interesting that that was mentioned as well. So then our other hypotheses were, do personal and professional experience predict how accurate someone is? And the answer is no. At least in this sample, there was no significant prediction based on personal experience, so whether someone knew an autistic person in their own lives, whether they were autistic, or professional experience, so how many autistic people they'd worked with didn't significantly predict it, whether or not they'd had training didn't significantly predict accuracy either. So that was different to what we predicted. And then in terms of whether or not it predicts whether people would make adaptations, interestingly, well, spoiler alert, no, personal and professional experience doesn't predict adaptations. But when we looked at that answer, so the question we gave to participants was, would you make adaptations to the support provisions you provide? And the majority of people across the vignettes, with the exception of the control vignettes, said yes, they would make adaptations to support. So that was quite interesting. So I'm currently looking at the qualitative data, so the data that outlines the open text box that said, if you were going to make adaptations, what would they be? So I'm currently in the process of looking at that data. At the moment, I've only looked at it for the traditional autism vignette, so I'm not able to draw comparisons compared to the nuanced autism vignette. But I'm using the framework, the SPACE framework that was developed by Mary Doherty, and this was developed for adaptations in healthcare settings, and I'm applying it to the homelessness context. And interestingly, the predominant adaptation that people said they would make for this vignette was that predictability aspect. And you probably won't remember what the vignette was I read out, but in the vignette it explicitly states that a person asked for appointments in the same time in the same place. So it makes sense then that staff said that they would offer the predictability for that person. I think it's interesting to think if we hadn't said that, if that person wasn't able to advocate for their own needs, what would happen or what would be put in place for that person. A lot of people also included adaptations that wouldn't fit into this framework, and those included onward referrals. So there was a lot of people who said they would signpost to an autism service, or they would signpost to a mental health team. And as a clinical psychologist, that's quite interesting because at least in the base that I'm in Oxfordshire, there isn't a service that a person could be referred to. Community mental health teams are unlikely, unless there's a co-occurring mental health condition. Community mental health teams wouldn't be able to support a person who's autistic. And also the adult autism services aren't accepting referrals at the moment. So it was quite interesting that a lot of the support that people would want to access often doesn't exist. And that's a wider issue I'm sure that we can all comment on or think about as well. So headlines of what was found. The most accurate, participants were most accurate at labelling traditional autism compared to nuanced autism, psychosis and EUPD. The participants were least accurate at labelling EUPD. The accuracy of the label they provided and whether or not people would make adaptations to support was not predicted, or significantly predicted at least, by prior experience or training. And interestingly, the majority of staff said yes, they would make adaptations to support for not just the autistic service users, but the service users with co-occurring mental health conditions as well. So I've just added these sort of just thoughts I've got about explaining these hypotheses as well. These findings. So if we think about for hypothesis 1, we predicted that autism would be less accurately identified, and actually we found the opposite, at least for traditional autism presentations. And part of this could be explained by the increased discussion about autism at a national level. So there's been an increased representation of autism in media, whether or not we think that's an accurate portrayal, but there has been an increased discussion and portrayal of autism in the media. And also in terms of like locally at a homelessness context, there was a development of the Autism and Homelessness Toolkit, and that's been widely spread. There's the PDU that's doing amazing work about neurodivergence and severe and multiple disadvantage. So there is a big increase in awareness, I guess, of autism across the general population. So it could be explained by that. Interestingly, though, the nuanced presentation was less well understood compared to the traditional presentation. And I think this really highlights the need for an understanding of the broad range of presentations to make sure that people aren't missed, because that can be a pattern that goes through people's lives. And the earlier that someone gets support and is able to understand themselves and to be understood by others, the better outcomes that they have in terms of well-being, housing, mental health, etc. And then in terms of that finding around EUPD being the least accurately diagnosed, I know this isn't the purpose of the talk, we're focusing on autism, but there is a massive debate around, does personality disorder exist? The majority of people who have a personality disorder diagnosis have experienced trauma in some way or other in their life. So there is a discussion around whether we can reconceptualize EUPD as trauma. And that's also highlighted in our findings as well. So I know I didn't put up the labels that were given for that vignette, but actually a lot of participants had labelled that as complex PTSD or trauma as well. So that explains why that one was least accurately identified in this study at least. And then for the second and third hypotheses, we predicted that personal and professional experience would predict accuracy and whether adaptations were put in place. And neither of those hypotheses were statistically significant, even though the study was powered. So we had enough participants to, in theory, find a significant effect if it existed. This could be about the way we asked the questions. They were often open text questions. And also we only really asked about quantity rather than quality. We didn't ask particular details about what was the training you've experienced, or when you've worked with an autistic person, have you understood them, or what have you learned from them, or we didn't really ask anything like that. And there's so much more nuance, I think, to it, and so much more detail that we didn't capture within this study, which might explain why the variables that we had didn't significantly predict whether or not someone identified autism in the vignettes and whether or not they would make adaptations. And also, I think it just shows that actually people working in homelessness services are really good at identifying people's needs and can make adaptations and are open and willing to make adaptations to people's needs as well. The big thing that was highlighted in our research was also thinking about what needs to happen now, like what else don't we know. And it actually what always happens with the research that I tend to do is that we find we don't know so much, and although this has sort of shown that participants are able to, or staff working in homelessness services are able to recognize autism, or at least identify autism to some extent, and that they're willing and likely to make adaptations, we don't know what are the adaptations that are actually being implemented. This study didn't show that, and I'm not aware, please tell me if there is, about much evidence that talks about that. And also then about how are these adaptations received. So even if adaptations are put in place, are they appropriate? Are they effective? Are they collaborative? Are they discussed with that service user? Are they meeting their needs? And then if we think back to, is it the quantity or the quality of the training and the experience and the personal contact that you might have with the person, we thought it'd be interesting to have training measures, a study that looks at, before you do training, what is a person's knowledge, attitudes and behaviours about autism, and after training, and comparing that and seeing that, is there actually an effect of having autism specific training, or are there other ways that we need to be doing things and changing things and increasing that awareness in different ways. Also have limitations, and I'd be amiss not to mention them from us as well. So it's important to mention that this is hypothetical service users. These were vignettes that, although developed with people who have lived experience, and they were in theory validated to describe what we were hoping they would describe, it's not real life, so they are limited in the ecological validity. It's also important to recognise a response bias. So the study was titled Staff Recognition of Service Users' Needs, and therefore it's likely to be people who are more invested and interested in acknowledging and supporting service user needs that would be likely to take part. So there could be a bias in that sense. And also in terms of just online surveys in general, the people who are more likely to take in online surveys generally tend to be those that are more sort of helpful, and because they're giving up their time as well. So there is a response bias to that. That's not to acknowledge if you didn't take part. I recognise that you're busy as well. I realised that came out in a weird way. Large proportions of our sample had their connections with autism as well. So that pie chart on one of those slides had the majority of people had some connection to autism in their own lives, and that's not necessarily representative of the general population. If we think about the general population, about 1% of the general population is autistic, and yet in our sample, I can't remember the number off the top of my head, but it was really, really high number of people knew at least one autistic person as well. So that's important to hold in mind. It might have influenced our findings. And then we also didn't have an objective measure of autism knowledge either. We asked about if you'd had training, but we didn't have any measure of how much you understand about autism. And it's possible that would have then predicted how accurate somebody was. Okay, so the key takeaways. Staff working in homelessness services are really adept at recognising at least traditional presentations of autism. And staff working in homelessness services are likely to offer adaptations to support for service users with additional needs, regardless of whether that's autism or a mental health condition or something else as well. So that brings me to the end. Thank you very much for listening. I'd really like to thank the experts of my experience who helped me develop the vignettes, all the psychologists who supported in the validation phase of the study, all of my study participants, my supervisors, Doctors Alistair Churchard and George Lockwood-Estrin, and Tara Chappell, who's been really, really helpful in developing the whole study. And yeah, that brings me to the end. So thank you very much again. And I've got my email address on there if you want to get in touch in the future.
Oh, thank you for that, Vicky. That was really interesting. We've got a few questions, which I'll just go through. But if anyone's got anything else that they want to pop in the Q&A box while we're going through these, that would be great. So one of the questions that was asked was earlier on in the session, but then you sort of referred to this later on, so I don't know whether you've got anything else to add to this. So it says the acquired condition of borderline personality disorder, would that classify as a neurodivergent condition even if acquired?
Could you repeat the question? The acquired personality disorder.
Yeah, so do you want me to reread it?
Yeah, sorry, yes, please.
Yeah, no, that's okay. So the acquired condition of borderline personality disorder, would this classify as a neurodivergent condition? And then it's sort of in brackets, even if acquired.
So it's interesting. There are different categories of neurodivergent conditions. So acquired neurodivergent conditions that definitely exist. There are also sort of psychiatric neurodivergence as well. So it'd be interesting to think about which does borderline personality fit in. And I think it's interesting to think about acquired being as a result from trauma, or whichever way you want to conceptualize it. Would that then fit with acquired, or would that fit with psychiatric? My leaning is more towards that sort of psychological conceptualization, and acquired being more around brain injury or sort of more of a like physical acquiring of that. But it would fit in with a neurodivergent umbrella as well.
Oh, thank you, Vicky. There's another question here that says, what strikes me from your findings is that autism awareness is generally good, but that more training and awareness around personality disorders and its distinction from nuanced autism is needed. Would you agree with this?
Yes, definitely. And I think in line with the literature that talks about the misdiagnosis of autism as a personality disorder, and actually they are conceptually different things, and the way that you would approach an autistic person compared to a person with a personality disorder in terms of the support that you might offer and the way you might help them understand themselves or offer your understanding would be very different. So I think there is much more that needs to be done in terms of that understanding and the differentiation, that's a hard word to say, of the two conditions. So yeah, I definitely agree with that. It's a really interesting point.
Thank you. And this is the last point at the minute. So it just says, would be very helpful to get some analysis of the effectiveness of autism related training in improving responsiveness and support.
Mm-hmm. Yes, definitely. And I'm kicking myself because at the moment on my placement, I'm doing autism training, but we didn't collect any measures before. So it'll be hard to actually measure whether it's the effectiveness of it. We're gathering feedback, but it would be really, really interesting to have that data on what are knowledge and attitudes before and after. So definitely a gap in our understanding and our knowledge. Yeah, that would be really helpful to have.
Oh, thank you, Vicky. That's it for the questions then. I think someone just put something else in. So it just says, would it be possible to see the other vignettes, please?
Vignettes is a hard word. Yes.
Okay, yeah.
I always want to say vinaigrette. Yes, vignettes. Yes, we are trying to publish at the moment. So I was hesitant to put them all in here because we're in the middle of going through the sort of peer review process and things like that. But we are definitely trying to publish them, and as soon as that's available, I'm happy to share that as well. It's been submitted, so fingers crossed it won't be too long of a process, but I'll be very happy to share once it's published.
Oh, lovely. Thank you very much, Vicky, for that. And we'll finish a bit Sorry, there's another question that's just come in now.
We thought this might happen, Justine, it's fine.
So it says, what are the different types of neurodiverse categories that you mentioned just now, Victoria?
Oh, so this is interesting because I learned this yesterday from Amelia Draper in her talk at a conference I went to. So it might be better for Amelia to answer it, but my understanding from the talk yesterday was that there is developmental conditions, so that includes autism, ADHD, and then there are acquired, so that's more about brain injury. There was another one, Amelia, that I can't remember off the top of my head, so you might have to help me out. And then the other one was around the psychiatric conditions as well, under that umbrella of neurodivergence as well.
I don't know if you've got anything you wanted to add, Amelia. I can unmute you.
Sorry to put you on the spot, Amelia.
I have just allowed or enabled your mic, I think, Amelia, if you did want to say anything. Because I can't.
If not, I can chat with Amelia afterwards, and I'm happy to respond to that question. I can send an email or something if that would be easier.
Okay, thank you. Yeah, so I think if there's nothing else, then we'll finish the session a little bit earlier. But yeah, thanks ever so much, Vicky, for your presentation today, and thank you for everyone for attending and your questions for Vicky.